Hello friends, today we are going to discuss about treatment of depression in pregnancy. I am Dr. Suresh Badadmat, Professor of Psychiatry, working at NIMANS, Bangalore. In this video, I'll be discussing about assessment and treatment of depression in pregnancy. Depression affects 12 to 15% of women during their pregnancy. This antenatal depression is one of the strongest predictor for postnatal depression. Depression during pregnancy has a serious consequences on mother's health, fetus health, and also the outcome of childbirth. Let's look into the assessment. Especially on busy OPD, in obstetrics, the obstetrician need to ask two simple questions. The first question is, they need to ask the mother directly, during the past month, have you often been bothered by feeling down, depressed, or hopelessness? This is the first question. Second question is, during the past month, have you often bothered by little interest or loss of pleasure in doing things? So these are the two important questions which need to be asked to a pregnant woman. One need to be careful. When you are asking question, make sure the spouse or the family members are not around. The reason being is, if there are a sensitive information like domestic violence, marital discord, family discord, the mother may not reveal these depressive symptoms. Hence, one need to ask the mother or the pregnant woman when she is alone. Further, if you want to do a structured assessment, Edinburgh postnatal depression scale is being used widely across the world. What is this Edinburgh postnatal depression scale? This is a 10-item self-report measure scale which discusses about emotional distress during the pregnancy. It is used as a screening tool. Each item is scored from 0, 1, 2, and 3. The maximum score is 30 and minimum score is 0. This postnatal depression scale is not a diagnostic scale. It is more of a screening. That means you need to combine with a clinical assessment along with this scale, as it reflects women's experience in the past 7 days only. And you need to repeat this scale as often as possible to rule out depression, because pregnancy is a dynamic phenomena. As the pregnancy nears, the possibility of depression may increase. This scale starts with date, what is the week of pregnancy or postnatal, what is the name, and the instruction is very clear. Please select one of the options mentioning in the past 7 days only. The first question, I have been able to laugh and see the funny side of the things. Score from 0 to 3. 0 as much as I have always. 1 is not quite. 2 is not so much, and not at all. Second question is, I have looked forward with enjoyment of things. Third one is, I have blamed myself unnecessarily when things went wrong. Here, the third question starts with 3, 2, 1, 0. That means rating is reversed. Question number 4. Have been anxious or worried for not good reason. Here again, the scoring starts from 0, 1, 2, 3. Question number 5. I have felt scared, panicky for no good reasons. Again, the scoring is reverse. Question number 6. The things have been getting on top of me. Scoring starts from 3, 2, 1, 0. Question number 7. I have been so unhappy that I have had difficulty in sleeping. I felt sad and miserable. I have been so unhappy that I have been crying. And finally, the thought of harming myself has occurred to me. So 6, 7, 8, 9, 10. The scoring is reverse, starts with 3 and ends with 0. Any item is positive on question number 10 that means there is a suicidal risk. You need to assess thoroughly using Beck depression or suicidal intent scale. Clinical assessment has to be done. If required, admission should be recommended or else refer to a psychiatrist. Let's interpret the score. If the score is between 0 to 9, it is a distress and it is short-lived. Need not worry, but close follow-up is required. If the score is between 10 to 12, there is a presence of symptoms. Repeat the assessment next 2 weeks. If it is 13 plus, score is there is a likelihood of depression. Referral is must. Item number 10, as I mentioned, if it is positive, suicide risk is there and hence thorough assessment has to be done. So you have to be very careful. Just because you are using a structured instrument, Edinburgh postnatal depression scale, that doesn't give you any much diagnostic importance. It is only a screening scale. The clinical assessment take precedence here. That means combination of structured assessment and clinical assessment gives higher rate of positive diagnosis. Let's understand the treatment of depression. The first line of treatment is usually antidepressant or else psychotherapy. Psychotherapy has its own limitation because the access to psychotherapy is difficult. Further, the newer non-invasive brain stimulation is coming up. Further, electroconvulsive therapy has also been found to be very useful in pregnant women. Let's understand about the antidepressants in pregnancy. There are various studies which have looked into the efficacy and safety of antidepressant in pregnant women, such as sertraline, fluoxetine, citalopram, escitalopram, fluoxamine, except paroxetine. All these medicines have been considered as an expert consensus guideline as per FDA C, whereas paroxetine has been considered as FDA D. That means there is a clear indicators and evidence that it can cause cardiovascular defect in the fetus. If you look at the SNRI, venlafaxine, duloxetine, and milnacipran, here also they have been considered as C. The dosage remains equivalent to adult patient. Further, other antidepressants like buprenorphine, mirtazapine, trazodone, nefazodone has been used, but however, the data is limited. Tricyclic antidepressants like disipramine, nortriptyline, amoxapine, imipramine, amitriptyline, all these medicines are also being considered not safe during pregnancy. But however, please do remember, based upon the available research findings, at the same time, exposure, that is accidental exposure to medicines during pregnancy, case reports are available. Hence, choosing the old drugs is prudent over the new drug. The new drug, you may not have any information at all. Whereas the old drug, you know the impact of this medicine on the adult or the mother. However, some accidental exposure data may be available with regard to old medicines. Mood stabilizers like lamotrigine, atypical antipsychotics like aripiprazole, quetiapine, olanzapine, risperidone, ziprasidone, lurazidone, paliperidone has been considered. Lithium has also been used. But however, the data is limited. These are the medicines which can be considered during antenatal depression. Let's understand what are the concerns with antidepressants. Antidepressants usage during pregnancy has found to have some discussion with regard to teratogenesis. As usual, in general population, the birth defect is known approximately 3%. However, by adding SSRI, maximum it may increase by 1%. That means SSRIs are not known to cause teratogenesis or else does not increases the risk. There are 4 meta-analyses which have looked into the malformation or congenital malformation, especially in fetus with accidental exposure with antidepressant. These studies did not find any significant risk with regard to congenital malformation. With regard to tricyclic antidepressant, the available data is limited, and it is very difficult to say tricyclic antidepressant are very safe. However, studies from paroxetine has indicated it can cause cardiac malformation, especially in fetus. Hence, usage of paroxetine in pregnant women need to be thought many times. However, if the patient is well stabilized on paroxetine, either you change over to other medicine before planning the pregnancy. If the patient is already pregnant and accidental exposure of paroxetine has occurred, please continue paroxetine. There is no point in changing to another antidepressant because you are going to expose the fetus with the two different molecules, that is one paroxetine and maybe another sertraline. Hence, it is not advocated to change medicine once the woman becomes pregnant. Further, there are some studies which have indicated spontaneous abortions on SSRIs. There are studies which looked into the abortion on antidepressant and without antidepressant. There was no significant increase in risk in women who is taking SSRIs. Further, some of the studies looked into the preterm birth weight and also premature delivery. However, again, the data is limited. Some studies says, yes, there is a preterm birth and also low birth weight. However, strong evidence is available. One of the other is neonatal adaptation syndrome, or else poor neonatal adaptation syndrome. If a mother is on antidepressant and as soon as she gives birth to the child, then the antidepressant level in the serum of the child or the neonatal falls very fast, and this may cause withdrawal symptoms in the child. That is called as poor neonatal adaptation syndrome. This clinical syndrome is characterized by respiratory distress, cyanosis, apnea, poor temperature instability, feeding difficulty, vomiting, hypoglycemia, hypotonia, hypertonia, hyperreflexia, tremor, jitteriness, irritability, and constant crying. All these symptoms are self-limiting and decreases within 1 to 2 weeks. No need to worry. But however, in certain rare cases, there may be seizures. You may require to give certain medications. The data suggests that about a third of the exposed infants may have mild symptoms of neonatal adaptation syndrome. So no need to worry. There is no indication to decrease the dosage slowly during the third trimester. And decreasing the dosage can increase the chances of relapse in mother. Hence, it is advised not to decrease the dosage of medication during the labor. Certain studies have looked into persistent pulmonary hypertension. Some studies said there are few chances of development of PPH, that is, persistent pulmonary hypertension. But however, many of the studies have not replicated this. Similarly, autism has been found to be implicated with usage of antidepressant. But however, certain studies have also said that mother who is depressed can give birth to autistic child. Both the hypothesis of antidepressant causing autism or else depression causing autism is not clear. However, the data is very limited. Hence, we need to be very careful, and you should be very, very sensitive when you are educating about medication in a pregnant woman. The data at this point of time does not indicate whether it is antidepressant-induced autism or else depression-caused autism. However, the numbers are very less. Further, serotonin reuptake inhibitors are also known to cause inhibit platelets. Hence, there is a possibility of postpartum hemorrhage. One of the study which looked into the woman who is on SSRIs and woman who is not on SSRI, when they gave birth, the amount of blood loss without Antidepressant was 398 ml, whereas on medication SSRI it was 384, hardly 100 ml increase in the blood loss. That means, again, advocating not to use antidepressant during pregnancy is not advisable. To summarize, my dear friends, antenatal use of antidepressant does not seem to be associated with increased risk of major congenital malformation. There is a small increased risk of cardiac abnormality with regard to paroxetine usage. But however, always assess the risk versus benefit, educate the patient, that is the mother, spouse, and other family members with regard to take medicine, not to take medicines, the impact of depression on the child and the mother. However, in established severe cases or recurrent severe depression, please do advise for SSRIs. Let's look into the psychosocial treatment of depression in pregnancy. There are various psychosocial treatments have been found to be useful during pregnancy, such as cognitive behavioral therapy, interpersonal behavioral therapy, yoga, mindfulness-based CBT, and these treatment need not be given by experts such as psychiatrist or clinical psychologist. Even this can be given by community caregivers or else primary caregivers, and they have been found to be very effective. And it need not be in person. Certain studies have indicated even telemedicine-based psychotherapy is also useful. Hence, my dear friends, psychosocial treatment has found to be very beneficial in pregnant women who is suffering from depression. Even just a psychosocial support, supportive therapy has been found to decrease the scores of depression in pregnant women. Let's look into the systematic review of transcranial magnetic stimulation in antenatal depression. This was a study published in 2019 by Hebel and his colleagues. This study looked into the various impact of RTMS on antenatal depression. In this study, they found that there are few case reports and 3 studies which looked into depression in pregnant women and treatment with RTMS. Again, the RTMS protocol varied from one study to case studies and also with regard to other studies. However, RTMS was found to be very effective in treating depression, and it was found to be very safe in pregnant women and also on the fetus. Hence, my dear friend, the early reports clearly indicates RTMS seems to be safe and effective in treating depression in pregnant women. Let's look into the other non-invasive neurostimulation methodology used in pregnant women who is suffering from depression. This is a study published in 2020 by Antenatal and his colleagues. In this study, they looked into various brain stimulation mechanisms. One is repetitive transcranial magnetic stimulation, transcranial direct current stimulation, transcranial alternating current stimulation, trigeminal nerve stimulation, and transcutaneous vagus nerve stimulation were studied and looked into whether it causes any congenital malformation in the child and how effective in antenatal depression. They found that in this review, 21 studies where 2 RCTs looked into, one RTMS and another one is transcranial direct current stimulation. 4 open label trial in which 3 were RTMS and 1 was TTDS. 3 case report with RTMS, 12 case reports with regard to 9 RTMS, 1 TDCS and 1 alternative current and 1 TNS was found. And all these studies, although the numbers are very few, but they gave some stunning results. Although studies are very few, non-invasive neurostimulation in antenatal depression was found to be very effective. And this non-invasive neurostimulation holds promises, and it is found to be very effective in women suffering from depression during pregnancy. And available data suggested it does not increases congenital malformation or teratogenicity in the child. Let's look into the ECT in treatment of depression in pregnancy. There are two important reviews which have been published. One is in 2019, published in Journal of Psychiatric Practice. Another one is Obstetrical and Gynecological Survey, published in 2020. This study looked into 4 meta-analyses on the use of ECT. And here, ECT in pregnancy, though both the studies clearly said that ECT have been underutilized in pregnancy for treatment of depression because of stigma and also lack of access to treatment with regard to ECT. There are physiological differences in pregnancy that merits additional care to be taken, especially providing ECT, that to modified ECT, such as increased aspiration risk in mother because of pregnancy, aortocaval compression or inferior caval compression may lead to fetal distress, possibility of increased fetal heart rate changes, prolonged seizure should be kept in mind. Hence, fetal monitoring of heart rate to be considered when you are giving ECT in a pregnant woman, although it is not mandatory. But however, playing safe is very essential because you're not only dealing with a woman who is suffering from depression, but there is a child in her womb, or else there is a fetus in womb. That means we are dealing with the two lives. In most of the studies, electroconvulsive therapy is found to be highly effective and safe in treatment of pregnancy. Electroconvulsive therapy treatment in pregnancy requires multidisciplinary approach. Psychiatrist, obstetrician, anesthetist, and also maybe radiologist may be required when you are giving ECT in a pregnant woman. To conclude, my dear friends, there should be a massive awareness program is required to make aware about the impact of depression in a pregnant woman. It is essential to carry out screening of all pregnant women with regard to depression, and it should not be done once. It should be done in every follow-up of antenatal. SSRIs are found to be the first line of treatment in antenatal depression. However, except paroxetine. Before you start medicine, you need to discuss the risk and benefit of starting medicine, risk and benefit of not taking treatment. The impact of depression on the child and the mother need to be discussed not only with the person who is suffering from depression, but with the spouse and other family members. Do not switch antidepressant once the pregnancy has occurred. By switching from one antidepressant to another antidepressant, you are exposing the fetus for two molecules which is not required and unwarranted. The main reason is because exposing the fetus for two medicines is unwarranted. And you need to remember, treatment should be tailored and individualized based upon the woman's need, family members' need, and also the safety of the child. All these need to be kept in mind. However, the preliminary data with regard to brain stimulation, such a non-invasive brain stimulation has found to be very useful and safe in pregnant women, such as RTMS, TTDS, alternative current stimulation, and even electroconvulsive therapy has found to be very useful in pregnant women, my dear friends. Hence, please engage a mother who is suffering from depression, not only the mother, the whole family members, and provide care so that the depression is well under control and does not have impact on the mother and the child. Thank you very much for giving your valuable time. Stay safe.